I'm Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you're listening to JAMA Plus AI Conversations. My guest today is Dr. John Torous, a psychiatrist and an Associate Professor of Psychiatry at Beth Israel Medical Center. Welcome.
Thank you for having me.
Well, thank you. So I know that you host the JAMA Psychiatry podcast. So we'll get to that a little bit later, but I know most recently there was the House Committee on Energy and Commerce's hearing titled Innovation with Integrity, Examining the Risks and Benefits of AI Chatbots. And you are a leading expert in digital mental health, and you testified on these issues. So I wanted to talk about this on our podcast about your testimony. And can you tell us a little bit of background of what it was about and what you were advocating or what questions they were asking you as well?
Yeah. So it was very encouraging to see our lawmakers in Congress from many different states really interested in understanding first, what is AI for mental health? And then really focusing on the safety. How does it protect users' privacy, data, especially younger people, those under 18? What does it do for youth? And then really thinking about what is the federal government's role in this space. So clearly there's some hot button political issues there. But again, we've never, think when we have new technologies in healthcare, when social media first came out, we didn't really have a congressional oversight committee saying what are the risks and benefits. When apps started to get big a decade ago or even earlier, we didn't have a congressional committee saying, well, how are we going to use apps? What are the risks and benefits? So in some ways, it's really encouraging to see Congress thinking about it, talking about it, wanting to learn more, because we didn't see those early steps for other innovations in the space.
Yeah, I mean, my work also is in the field of social media research. And I think we just didn't know what it was and we didn't know what it was going to become. And I still don't think we actually know its potential, both in terms of gains and side effects.
Yeah.
And so there was no guidebook because we had never seen anything like that before. So it is nice to see that we're actually discussing it. And so from your perspective is with these, for instance, new AI chatbots and people starting to interact with them for mental health services, especially when it concerns youth.
Yeah.
What do you think the clinical evidence should be before we start to, again, either encourage it or, we start to prescribe it even?
Yeah. I think there's a lot of use cases in behavioral health and mental health and psychiatry. I would argue it's one of probably the largest use cases is kind of in the psychiatric space. It really has taken off, especially say in the last 2 years. And what's interesting about these large language models, this branch of AI, right? It's relatively easy to tell it, pretend to be a therapist, keywords pretend, or act like a therapist. And it'll try really hard, kind of like a puppy. If you tell it to chase a ball, it'll try really hard. Sometimes it'll get it right. Sometimes it'll run across the street and cause an accident. But the point is, the barriers to entry are very low in the space. And that's exciting. Everyone can almost build one a bot. We've seen teams on what was Character AI before it was banned building their own chatbots to help each other with probably more limitations than benefits overall. But the point being, when the barriers are so low to developing them, we want to make sure that we have good ways to evaluate them and make sure that they're actually going to be useful. So just because you can do it definitely doesn't mean you should do it, or it's going to be effective, or it's going to be safe. And one of kind of the guiding principles I do is, I don't know if you guys were part of it, but there was the JAMA Summit report on AI that came out earlier this summer. Very good reading on how to think about these things in different use cases, what type of evidence to bring and not to bring. And again, there's a very convergent message. What I told Congress, and even Congress agreed, is we want to see rigorous evidence. So in my world, behavioral health, we have some chatbots of evidence, but they'll do an RCT, a randomized controlled trial. What again is what we celebrate here at JAMA, like the highest level of evidence is an RCT. But what if I told you the control group was nothing, a wait list, and the other group got to use a chatbot and it was interactive and they had all these expectations and hopes, and their group gets nothing. And after 2 weeks, you say, who feels better? The group that did nothing or the group that did all these different things? And so the point is, in behavioral health and psychiatry, we have to be cognizant that there's expectations, there's placebo effect, there's performance biases. And what I told Congress and we agreed on, so we got Congress to agree on something, was we should do fair science to compare apples to apples. So if you come to me and say, John, I want you to use my chatbot with your patients, it's evidence-based as RCT, I'm going to say, well, did you compare it to a chatbot that talks about the weather? That's not a hard comparison, but I want to know that you've isolated the active ingredient. What is it doing for therapy? Not that you've just tried to, again, repackage using a chatbot as a novel, exciting experience for people. And oddly enough, we have not seen a high-quality randomized study that's been replicated that really does that. And that is, again, what I testified to Congress under oath. So I said I can tell it to you here. But that's a little bit terrifying, right? We're not asking for a horribly high bar, but no one has yet been able to meet that very low bar. So I don't think anyone would pass, even again, what was in the JAMA Summit report on AI even. And so it's out there. We know what we need to do. We just haven't seen it done yet.
That's so fascinating. I mean, I've seen some of your presentations and I really enjoy them. I don't remember the video, but it was, you give an example of, I think someone's watching elephants or like bunnies or something, and they compare it to nothing and it does better because it's something. And I think that's a really important thing to highlight, right? Is that, yes, it can be placebo, which I always also try to gauge myself 20%. So am I 20% better or am I more than 20%? Because placebo is around 20 to 30%. But just that interesting aspect of, the control being something that needs to be focused on. But do you think it's more of a publication bias where there might be no results? If people are maybe doing kind of these smaller type of trials with a control that is, let's say, standard care or maybe another chatbot, and they don't see any results. And so they either they don't submit it or, unfortunately, journals don't accept it because it's not this shiny new tool that is successful.
Yeah.
Again, I'm not saying JAMA does that. I'm saying that this publication bias is very, very common.
I think there has to be publication bias, right? Because we're seeing all these studies come out. And again, if chatbots were this fantastic for mental health, we would see them turning the dial on what's happening in the mental health crisis per se. So in some ways, I always like to say the proof is in the pudding in what is happening around mental health overall. And so again, it's not to say there are some really great studies coming out. I have seen some negative studies, but I do think there's a bias and again, what people want to study, what they want to publish, and again, what some journals may want to do. But if you think about the scientific process, we're only going to make these chatbots effective and safe for people if we learned from how they worked and didn't work, right? If everyone says, my chatbot works 100% of the time, it has no weaknesses, it's perfect, you almost go, that's remarkable because Google doesn't make that claim, OpenAI doesn't make that claim, Claude, Perplexity, none of the big companies make that claim. So somehow you have done better than some of the largest companies of all the resources in the space. And I'm open to small people doing a great job in this space. But I think it was Isaac Asimov said extraordinary claims and extraordinary evidence. And I think what we're perhaps both getting at is we don't need AI exceptionalism when it comes to will help with mental health. Yes, there's a mental health crisis. Yes, we want people to get more access to care. No one denies that. But saying that because we don't like the mental health system today, we should use a chatbot that has no evidence, that could have safety risks, really is just unethical if we get to the core of it. And again, the bar that we're asking for is tell us it works in a rigorous way. I would hope that people developing it want to reach that bar too. And I think I'm in 2026 and onwards, we will see that because again, if it's relatively so easy for everyone to have their mental health chatbot, you're going to have to compete based on safety and efficacy to show it works. And that's a wonderful thing, right? We want competition. We want small people in the space. And the research process is what can, again, reward the right ones and protect people from the ones that aren't going to be useful. So I think asking for rigor doesn't mean you're anti-innovation. And one thing I think that came up in Congress was that too, is no one is saying we want to be anti-innovation, but we want things that are actually effective.
No, I think that's very well said. I love the point that you made is the proof is kind of in the, I'm paraphrasing, but population pudding, right? Is the population changing? And how do we kind of move forward with keeping innovation? But what type of guardrails would you say that we need to then have in place what would you tell policymakers in order to prevent these type of chatbots from, entering that mental health space too rapidly?
Like in part, like we're seeing these lawsuits happening around alleged suicide deaths from these chatbots. So we're seeing the judicial system is already active in this space. So if the judicial system is setting the precedent, we're far behind of where we need to be, right? I don't think anyone wants there to be tragic outcomes that juries and judges and lawyers have to pick how we get to use the technology. So that's our signal that we can do more. And I think we'll get a better sense again on what is safe. I think it's easier to define. We can have some sense of what harms are. We don't know all the harms of these AIs today, but we can at least say what are the harms we want to avoid as one step. But the real question is, again, what does good look like? And I think that's going to be important that we as a field define what is good enough. Because what happens is, especially in mental health, we have a lot of different outcomes. We have subjective outcomes, we have clinically rated outcomes, patient ones, we have some markers, and we need to, again, have a consensus of what is rigorous enough research and what is a good enough outcome. So again, I would argue if you have no control group and compare yourself to a wait list, it doesn't really matter what you did. It's great to show feasibility. I think it's quite proven now that people with mental illness, of course, they can use a chatbot. That was never in question. So I think what we have to do is, again, establish some rules of the road is what is rigorous research and what is an outcome that is meaningful and good enough. So I think if we can align everyone on what we need to do, I think both industry and academics will rise to the occasion, right? In essence, we're not saying no one can do it. We're just saying, let's agree on some benchmarks of what is good and let's have everyone work on that. Because right now is everyone says, well, my chatbot made people 1% better, 10% better. It made people better on this scale or this scale. So everyone is right that they have some benefit, but it's almost impossible to kind of understand what they're all really doing and how they work. And with so much fragmentation, you're not going to get progress. And in my space, I kind of looked to the mental health apps. Again, they were a lot of mental health apps, a lot of companies, but they kind of never had the impact they wanted. And I argue it's not that mental health apps don't work. It's just they never could kind of define that bar for quality, acceptance, and get a lot of trust and buy-ins. So I think that we have to be careful that AI for mental health doesn't follow kind of the same, dare I say, rise and fall of the mental health app.
Okay, well, let me ask you that question. Do they work? Do they actually work? And then the other one is, what outcomes would you measure?
Yeah, so I think they probably work as well as a self-help book that you buy at a bookstore.
Oh, interesting.
And for some people, that can be useful.
Mm-hmm.
For most people, probably not enough, but with some coaching and support, it could be useful. So I think of it more as a tool. Just like, again, anyone could go buy a book from a bookstore. We have no concerns. You can try it. But it doesn't really solve the mental health crisis. And in this way, we've kind of given everyone a self-help book that's interactive. So it's a little bit better, but I'm not sure alone that, again, changes the clinical needle on kind of population level outcomes or what people need. We don't, again, no one has kind of shared publicly in a rigorous way that they can do more than that. I think what's an exciting development is we're going to be able to move beyond, say, just did your depression scale change, your anxiety scale change? We now live in a world where the phones can monitor sleep, steps, screen time, functional outcomes, and we have the computing power to make use of it. So you can imagine there's a new world where, of course, we ask people their experience. Do you feel better? Do you feel less stressed? Do you feel less depressed? But then we can say, is that actually making a real world functional outcome difference? John feels less stressed and he's able to go to school more. John feels less anxious and he's having stronger relationships. So I think what we're going to see is we've always known that unique functional outcomes improvements are what's key to mental health. And technically, if you want to be nitpicky and read the DSM, it's not actually a diagnosis unless there's a functional impairment. That's kind of the part that gets forgotten. So I think that we're going to soon see is not only can the LLM make you feel better on a scale, but does it show the real world functional outcome that kind of shows it has value? And that would be tremendous because then we know we're actually helping people.
Is that like something like when you say functional outcome, is that something like employment, for instance?
Exactly. It could be employment, it could be relationships. And for a long time, I think the field of, in psychiatry, we've known that functional outcomes can matter the most. But it's been very hard to quantify them, right? Because we have to kind of ask people these long questions about functional outcomes. And again, without judgment, as we move towards a more digital world, there's a lot of ways to quantify functioning in the digital space. And I think that's going to be a win for just developing lots of new treatments in the psychiatric space. We'll actually be able to see what matters to people and do we actually help them achieve the goals that they want.
Yeah. Okay, so now I'm going to slightly then have you put on your JAMA Psychiatry host hat
Yeah.
and tell me, have you spoken to anyone or have you learned about any interesting tool or study in the realm of AI and mental health that you do think has that potential to be able to shift population mental health outcomes?
I think as you can see, what we're talking about is AI can do anything today, right? You could say, be my therapist, and now, well, be something else. So the point is, it can do a lot of things today that we may want or not want. So it's not like a drug in the sense that it's a fixed compound and molecule. It doesn't really change with time. And if you think about it that way, I think the challenge that all of us have coming up is, again, how do we shape this thing that can be anything to be the thing that we want it to be? And how do we encourage it to be that way? So I think that benchmarking efforts become very important. And again, the idea of a benchmark is you want to say, how good is an AI at a task? Let's say, how good is it at that giving therapy to help people with depression? I'm going to make up a broken a leg. I don't know if that's a thing, but you would again have some very specific questions written by members of that community with experience. And you would kind of say, what would we want an AI to do? What are the right values, information, content messages? And a benchmark is kind of the way to give the AI a kind of complex interactive quiz to see if it gets it right. And what's nice about it is then you can feed in any AI. You can say, I want the Google one, I want the OpenAI one, I want the Perplexity one, I want the startup one. And you can kind of see how they each come back and what they do. And that's useful for two reasons. It lets people say which ones seem to be better at tasks. We're not saying to use it, but you can at least compare. But also gives the tool makers, the AI companies, feedback that they need to improve it. Like no AI company wakes up and says, we're so glad that people are suing us and that people are unhappy, right? That they want to get better, but they say, what does better mean? So a benchmark is a way to kind of communicate to them. And it's a way to communicate and inform patients and families and clinicians. So I think once we have benchmarks helping us steer AI in the right way, I think we'll become a lot more productive of what we can do and not do. Because right now, it's so hard to take an amorphous thing, right? And say, well, it could do this if we tell it really carefully to do it. And I want to test on all of the AIs, right? I'm not here to endorse any one of them. I want to see which ones do well on certain things. And I think you can see we're getting more towards informed decision making, right? Understanding risks and benefits. We're not saying benchmarking means you should go out and use an AI that passes it, but we need to have that basic level of having some informed decision making because else it's not really medicine, or it's not really clinical, right? It's more just it's kind of in that wellness space. Here's products, vitamin C. He gets a lot of claims in my drugstore aisle on what vitamin C can do. That's fine. But that's kind of where the AI has ended up, right? There's a lot of these pretty thorny controversies in it. But I think, again, the way out of these controversies is let's just get transparent data. Let's talk to more people about what they're doing. Let's talk about those risks and benefits. Let's have AI take expert designed quizzes and information. And I think that will at least give us a better baseline of what to do next than kind of saying, well, theoretically, we think X, Y, and Z, so we should do this.
Mm-hmm. And can you describe like a real world example of like a benchmark that's currently being used, for instance?
So none of them are, again, being deployed at scale, but there are some around, say, suicide prevention.
Mm-hmm.
So the case would be a person would call, say, a suicide hotline because they don't feel well, and clearly we'll say the suicide hotline is 988 for anyone listening to this to call. But it would say, again, like scenario A or B. Should the helper on the end say, I'm so sorry to hear that you're calling me, or should the helper say, let me connect you with resource A, B, and C? So it's not that there's a perfect right or wrong answer, but you want to kind of give the benchmark as like what should happen next in an adventure. And you want experts, be those patients, families, clinicians, to vote and say, what is the best answer that we think is appropriate? And again, it's not as easy as like, there's always like you do this or this, but you want to kind of, again, have the benchmark be a set of cases that the expert community votes on, but then the computer or the machine or the LLM tries to vote on. And you can say which machines or LLMs get where we're going with it, which one's following. So the benchmark is a way to really assess the reasoning capabilities of these machines.
And I really also like how you talked about kind of the community and the patients, kind of being involved to say, what answers best. You rarely kind of hear clinicians say that they should be involved in that type of decision making. And so how would you get their involvement, either in studies? Is it in Congress, policy? How do you start integrating their type of feedback?
Yeah, I think given that a lot of these large language models are going directly to patients, again, there's a world of AI scribes. We'll not talk about those today. And there's different administrative uses of AI. But a lot of the clinical facing ones are going directly to patients. So I think it's critical to have patient involvement because else it's us making up rules and guidelines for things that are going directly to patients. I mean, I can say from our experience, our team is excited to work with NAMI, the National Alliance on Mental Illness. It's the largest grassroots mental health organization representing millions of Americans and their families with mental illness. So we approached NAMI directly and we said, you are the organization we want to work with because, again, you have the experience, the values, the on-the-ground people doing it. Can you work with us to help create benchmarks, as we talked about? And we're very fortunate they said yes. But I think there's a climate now, whatever field you're in, I'm going to make it up from dermatology to surgery. I think these are the partnerships we need to make now. Because again, large language models they're taking all the information from patients, right? Or notes about patients, producing it and trying to bring something out that's going to work for patients. A lot of them we're talking about. So it really makes sense to partner with those patient-facing groups and kind of to bring their voice, their experience, their expertise, because else I don't think we stand a chance, if that makes sense, it's hard for us to then say, why would our benchmarks be valid? Is the question. Like, I guess it gets back to benchmarking is the technical part, but it's really about trust, right? It's saying, can we build some criteria together? And do we trust those criteria enough that if something passes it, we think it's useful to use? So I think if you're trying to build these tools for trust, make sure you build the benchmarks in a very inclusive, trusting way is going to be important because there's already hundreds of benchmarks. You can probably just put into your favorite search engine benchmark for any condition. They exist. Are you going to trust them all? I don't know. Just like, are you going to trust all the LLMs? I don't know.
Yes. Thanks, John. This was an amazing conversation. And I really appreciate you going through your time testifying and all of these kind of case and points that you have made throughout this conversation. Is there any last ending thoughts that you have?
I think even if you're a clinician, family member, patient who doesn't want to use LLMs, that's perfectly fine and good. Still play with them. They're free. Understand what they do, see their limitations. Again, I'm not saying you should use them. Clinically, we know that the AMA says they should not be used for care at this point. But I do think getting some hands-on experience will make you much more informed when you advocate about the risks of them, even why you don't want to use them. And if you do want to use them or you're developing one, just again, you can do it the rigorous way. It's not going to be that much more complex, but it's going to have a tremendous amount more impact.
Thanks, John. I am Yulin Hswen, Associate Editor at JAMA and JAMA Plus AI, and I've been speaking with Dr. John Torous. You can find a link to the article and this episode's description. And for more content like this, please visit jamaa.org. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Moreau at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.